Hello everybody, good afternoon to you all. Hope that now you are keeping your good health and best of the moods. And I appeal you, in this pandemic, you must have a positive attitude towards everything. And I am damn sure, as a medicos, we will overcome this means that a recent problem. Okay, now coming to today's topic. As you know that, say we were talking here about the say blood pressure, and we have seen say various things. And what we were discussing last time, that was the mechanism for blood pressure regulation. We have seen there are two mechanisms. That is, one is what we call it as local regulatory mechanism, and second is that is the mechanism entirely based on the nervous and the hormonal control. Then we were discussing that is the other that is category of the blood pressure, where I have told you this blood pressure is divided into three categories depending on the time duration taken by these regulatory mechanisms to regulate the blood pressure. Now they are, as first is the rapidly or short acting mechanism, then second is the intermediate acting mechanism, and third is the long term acting mechanism. If you remember that, we are discussing here that is about the rapidly short acting mechanism, and in this that we have completed here, that is the function of baroreceptors and the chemoreceptors. And if you remember that, I will not go in that much detail. Before that, we have seen which are the regulatory centers in our brain, that is especially the medulla, and they are called the vasomotor center. Now further, this vasomotor consists of vasoconstrictor area C1, vasodilator area A1, and cardioinhibitory area. Apart from that, at the posterior lateral portion of the medulla and the lower pons, there is other center, what we call it the sensory area 2. Then also we have seen where these baroreceptors and these chemoreceptors are located. The baroreceptors are mainly located at the arc of aorta, and secondly here the other receptors which are present at the carotid sinus, at the internal carotid artery, and they are innervated here by that is cranial nerve. The baroreceptor which are present on the arc of aorta, they are innervated by 10 cranial nerve, that is the vagus nerve, and that is the baroreceptor which are present at the internal carotid artery. That is what you will find that they are present at the carotid sinus, and they are innervated by glossopharyngeal nerve to the Heyring's nerve. And we have seen that how do they function, and we have also seen their classification: high pressure baroreceptors, low pressure receptors, according to the their function or physiological classification. Second category we have seen is the anatomical classification. That we have seen they are present in the arteries, and they are called the arterial baroreceptors, then cardiac baroreceptors, then there are two qualities, atrial receptors and pulmonary, venoatrial receptors, and the second category is ventricular receptor. Then where they are located, where they are innervated, that all of this we have seen. And also that is we have also discussed here, that is the function of the chemoreceptors. I think that chemoreceptors also I have just mentioned here, but I would like to summarize here where these chemoreceptors are present. They are present at the arc of aorta, and they are present in the that is the other bifurcation of the carotid artery, that is especially external carotid artery. They are also innervated in the same way by the 10 cranial nerve over the arc of aorta, and 7 cranial nerve at that is the bifurcation of that is the carotid artery. Now these are the carotid bodies and the aortic bodies. These are called as the bodies. And now what is their function? Now since they are called as that is the chemoreceptor. Now they are present outside the brains, hence they are called as peripheral chemoreceptors. Now they are sensitive to what? They are sensitive to change in the partial pressure of carbon dioxide, partial pressure of oxygen, and also they are sensitive to the hydrogen concentration, that is the pH of the blood. Now they are connected to the respiratory centers, that is via 9th nerve, that is especially carotid bodies, and 10th nerve, that is the aortic body. They are also sending the afferents to respiratory center as well as cardiac center in the vasomotor center. When there is increase in the partial pressure of the carbon dioxide, that we call the hypercapnia, and decreased partial pressure of oxygen, hypoxia, or decrease in the pH, they are stimulated and lead to the stimulation of, that is, respiration. Same time, they also here cause, say, stimulation of vasomotor center to, say, that is the effect, that is the blood flow and that is the blood pressure. The carotid bodies are located on the external carotid arteries near their bifurcation with the internal carotids. Each carotid body is few millimeter in size, that is approximately 1 to 2 millimeter size, and has the distinction of having the highest blood flow per tissue weight of any organ in the body. When they receive, say, that is the maximum, say, blood supply, that is, as it is said that 2 liters per minute per 100 gram of the tissue. Secondly, the aortic body is located in the region of the aortic arch, and the roots of the major arteries in the thorax are innervated by efferent and afferent fibers coursing in the aortic nerve, branches of the vagus, and these organs are also supplied with sympathetic efferent fibers. Now there is another category, as I already told you, they are called as central chemoreceptors. These are the cells or neurons which lie just beneath the ventral surface of the medulla oblongata, and therefore called as the medullary receptors, or they are called as the central chemoreceptor. Neurons of central chemoreceptor project directly over the respiratory centers, which are slightly deeper to central chemoreceptor, pulmonary, and they are, say, categorized as we know the pulmonary and the myocardial chemoreceptor. Remember that when these afferent impulses to the respiratory centers, these centers lie just adjacent to each other, and in some of the books you will find that when the respiratory centers are stimulated, same time there is a spillover of this afferent impulses to the nearby, say, that is vasomotor center, and they also affect here, say, that is the cardiac activity. Now just concentrate on the carotid body. The carotid body is a chemoreceptor located in the adventitia of bifurcation of the common carotid artery. Now how do they function? Chemoreceptor functions as carotid body monitors the blood's pH, partial pressure of carbon dioxide, and partial pressure of oxygen, and thereby they modulate cardiovascular and the respiratory function primarily through the sympathetic tone. When the carotid body sense acidemia, hypercapnia, or hypoxia, autonomic firing leads to increased blood pressure, heart rate, and respiratory rate. That I will tell you very shortly. The function of the carotid body is complemented by other chemoreceptors, most notably the aortic body located in the aortic arc. Now they are located in the bifurcation of the common carotid artery. Their average size is about, say, this carotid body is about 3 to 5 mm in diameter, and average weight is approximately 12 milligram. Their blood supply, they receive the blood supply from external carotid through the Meyer's ligament, which provides attachment to the carotids. They are innervated, say, through glossopharyngeal nerve via Herring's nerve, also called as, that is the carotid sinus nerve, originating 1.5 cm distal to jugular foramen. Now this carotid body consists of, that is the two receptor cells, say type 1 and type 2. The type 1 cells are called the chief cells, and the others, say, they are supporting cells, and they are called as sus-tentacular cells. Now what is the function of chief cells or type 1? They are derived from neural crest. They release here acetylcholine, ATP, dopamine, noradrenaline, and substance P, and metenkaphalin, that is metenkaphalin, in response to activation. And the sus-tentacular cells, these are type 2, say, these are the, say, what is their function? They function as a supporting cell. Now the chemoreceptor, just concentrate on, say, peripheral chemoreceptors. Now these receptors in the carotid sinus and the aortic arc sense change in the partial pressure of oxygen, partial pressure of carbon dioxide, and change in the hydrogen concentration. When the blood pressure falls less than 60 mm of mercury, mean these receptors in carotid sinus and aortic arc detect decrease in the partial pressure of oxygen, increase in the partial pressure of carbon dioxide, and decrease in, that is, the pH. Now very crucial aspect is that they are more sensitive to the change in the that is the partial pressure of oxygen, means that is the decrease in the partial pressure of oxygen is immediately sensed by this chemical, that is the chemoreceptor, when the blood pressure falls below 60 mm of mercury. Especially carotid bodies, also called as chemoreceptors in carotid sinus, they transmit to the brain stem via carotid sinus nerve, just I have mentioned. Carotid sinus nerve joins with the glossopharyngeal nerve, that is ninth cranial nerve, and this ninth cranial nerve synapses in the nucleus tractus solitarius of the medulla. Then coming to the aortic body, they are also called as chemoreceptors in the aortic arch. They are innervated by 10 cranial nerve, or they transmit to impulses to the brain stem via vagus nerve. 10 cranial nerve synapses also similarly in the nucleus tractus solitarius of medulla. Now the second category, that is the central chemoreceptors. These receptors are situated in the medulla, as I have already told you. They have ability to detect the change in the or decrease or increase in the partial pressure of carbon dioxide. Similarly, decrease or increase in the pH. But remember that they do not have the ability to detect change in the partial pressure of oxygen. Now they detect these all changes in brain fluid. Central chemoreceptors are not stimulated by hypoxia like other cells. They are depressed by hypoxia, that you have learned while studying in the respiratory system. Partial pressure of carbon dioxide and pH is influenced by arterial carbon dioxide. If you remember how this carbon dioxide transported across, that is the blood-brain barrier. Then coming to the peripheral chemoreceptors. These chemoreceptors are sensitive to changes occurring in the chemical composition of the blood, and they show response to chemical composition and also same time the change in the partial pressure of oxygen, carbon dioxide, and change in the pH. They are structurally and functionally different from baroreceptors. Why? Because baroreceptors sense the change in the blood pressure, not the chemical composition, hence they are different. The major function of chemoreceptor is to regulate respiration. They also help to regulate blood pressure whenever there is a decrease in the partial pressure of oxygen, or increase in the partial pressure of carbon dioxide, or a decrease in pH, that is increase in hydrogen concentration. In this situation, chemoreceptors will be stimulated. Just remember, these are the three conditions where you will find that chemoreceptors can be stimulated. On stimulation of these receptors, now this afferent fiber which are arising from carotid body transmit impulses through ninth nerve to the medulla, and afferent fibers from aortic body transmit impulses to the 10th cranial nerve. These impulses reach medulla, and from which stimulatory impulses are sent to the cardiostimulatory center and inhibitory impulses are sent to the vagal center. Okay, this is the function to of this chemoreceptor. When there is a fall in the blood pressure, in short, now once again concentrate the vasomotor center, what will happen? So since due to a decrease in the blood pressure, this chemoreceptor detect the change in the partial pressure of oxygen, carbon dioxide, and same time change in the pH. Why once again I repeat, why it has occurred? It has occurred due to the decrease in the blood pressure. And what happens next? Now these change through carotid body and the aortic arch, aortic body, they send impulses to the medulla, and from which, remember, now they stimulate here cardiostimulatory center and inhibit, that is the vagal center, or what we call the cardio-inhibitory center. Hence, now due to this stimulation of the cardiostimulatory center, there is increase in the heart rate, there is increase in the force of contraction, and also increase in the cardiac output, and there occurs generalized vasoconstriction, and all factors now these help to increase the blood pressure. Chemoreceptors are stimulated when blood pressure falls below 60 mm of mercury, because at this pressure there is relative hypoxia of chemoreceptors. They will prevent further fall in the blood pressure. Now the second that is the response, the second category that of the rapidly acting mechanism is that is a CNS ischemic response. Ischemia means what? Lack of the blood pressure supply to the tissue. The CNS ischemic response also starts working when blood pressure falls below 60 mm of mercury, and increased response is seen when blood pressure is between that is 15 to 20 mm of mercury. Just try to understand here, that is they will respond when the blood pressure falls 60 mm of mercury, and they will maximally stimulated when the blood pressure is in the range of 15 to 20 mm of mercury. This is generally seen during some of the conditions, for example head injury, intravenous infusion of epinephrine. This pressure is very low pressure, and CNS ischemic response is more or less as last attempt made by body to bring back to normal. Blood pressure back to normal means this is last attempt of the body. Okay, when there occurs the CNS ischemic response, and it helps here to bring the blood pressure back to the normal. Ischemia of the brain occurs when does it occur? When there is an increase in the intracranial tension, which cause a similar response to increased blood pressure, that is the sympathetic stimulation. It will cause the same type of a response, just say that is due to the increase in the cranial tension, and that is identical to the sympathetic stimulation. This is called as Cushing reaction. This is also called as Cushing reaction, which was this reaction was discovered in the New York by Harvey Cushing in year 1901. Now when blood flow to CNS decreases, there is accumulation of carbon dioxide to great extent. What is next? There is increase in the carbon dioxide within neuronal tissue. This will cause increase in the partial pressure of carbon dioxide, which stimulates vasomotor center very actively to cause large increase in the blood pressure. Hence, increase in the blood pressure helps to restore some degree of blood supply to the brain, and this will cause removal of, or help here to cause removal of carbon dioxide, and helps here to restore or helps to supply here oxygen. This ischemic response helps to relieve ischemia. Stimulation is caused by strong action of vasomotor center, which causes severe vasoconstriction of peripheral blood vessel. This also increases peripheral resistance, and that is the blood pressure. In physiological nervous system, response to the increased intracranial pressure, which results in Cushing's triad, there are three changes are occurring. That is called as the Cushing triad. What is this? When it occurs, when there is increase occurs increase in intracranial pressure, there occur three changes, and that is called the Cushing's triad. You will find that there will occur increase in the blood pressure, irregular breathing, and bradycardia, slowing down of the heart is observed. Intracranial pressure increases pressure in the fluid and becomes equal or becomes more or gradually exceeds mean arterial pressure, which cause compression of arterioles in the cerebrum. Remember, and this compression causes diminished blood flow to the brain and develop cerebral ischemia. Why does it occur? Because when intracranial pressure increases, either it becomes equal or it increases above mean arterial pressure, and which causes compression of the arteries in the cerebrum, and that leads to the cerebral ischemia. Now the next category under rapidly acting mechanism, if you remember, that is low pressure receptor. Now where these receptors are found? These receptors are found in the right atrium and in pulmonary artery. These receptors are basically baroreceptors, and function in the same way like systemic baroreceptors. Whenever there is increase in the pulmonary pressure, these receptors will be stimulated. You know the mechanism when baroreceptors are stimulated due to the increase in the blood pressure. Now second, say there is one interesting reflex that we call as the Benbridge reflex. It is say that when, in short, say we teach generally the experimental physiology, whenever there is an increase in the or whenever there is an accumulation of the blood volume in the venous side, that will cause reflexly increase in the heart rate, and that will maintain the blood pressure. Now Benbridge discovered this reflex in year 1950, that the rapid infusion of a large volume of saline into the venous system causes a transient tachycardia, may be due to the due to the stretching of activated channels. These channels means what? The stretch channels are present across the membrane, may be due to the activation of that is the stretch activated channels. Benbridge reflex helps to prevent accumulation of blood in the right atrium or in pulmonary circulation. Now increased filling of the atrium or atriocaval region by large intravenous infusion of the blood or saline causes increase in the arterial pressure and cause now increase in the heart rate or tachycardia up to 75. Hence in the beginning I told you, Benbridge reflex is what? It is nothing but accumulation of the blood at the venous side which causes reflexly increase in the heart rate. This effect is observed only in the intact animals and in the number of other species. The heart rate response to the arterial filling in the human seems to depends on the existing heart rate at the time of application of the stress. That is, lower the existing heart rate, the greater the increase in the increase in the venous wall. Now different the researchers or investigators reported different observations suggesting that this reflex probably plays a secondary role in cardiovascular regulation. Now the stretch receptors of atria which produce or elicits Benbridge reflex transmit their afferent signal through the vagus nerve to the medulla. Then efferent signals are transmitted back through the both vagal as well as sympathetic nerve to cause increase in the heart rate and presumably the strength of contraction. Thus, this reflex is important which helps to prevent damming or pulling of the blood in the vein and the atria and that in the pulmonary circulation. Now comes here that is the volume receptors, the third category. Now these receptors are present in the atria as well as they are stimulated when there is an increase in the blood pressure. When the receptors are stimulated, they cause here two different responses. What are they? They cause increase in the urine formation first by causing constriction of the afferent arterioles in the kidneys and increase in the filtration. These volume receptors inhibit the secretion of hormone called as ADH, antidiuretic hormone, which cause here diuresis, and the ADH prevents diuresis, that we know the function of the ADH. Therefore, when ADH is inhibited, there may be increased formation of urine. Whenever there is increase in the blood pressure, there will be increase in the urine formation, and this in the urine formation is that is prevented by lack of ADH. And the net result is that there occurs increased water loss from the body and extracellular fluid, blood volume, and due to this, blood pressure comes back to normal. It helps to maintain normal blood pressure. These receptors are present in atria and are stimulated when there is increase in the blood pressure. When the receptors are stimulated, they cause two different responses. They cause increase in the urine formation by causing constriction of afferent arterioles in the kidneys and the filtration. Now here why I have taken this point here, that is causing increase in the filtration. That is, therefore the vasoconstriction takes place only in the arteries before the glomeruli, and this vasoconstriction leads to the increased hydrostatic pressure which propagates to the glomerular capillaries. The blood flow rate and the velocity do not change. Therefore, the increased hydrostatic pressure works against the constant pressure of Bowman's capsule and osmotic pressure of the colloid medium, and which cause increase in the net filtration pressure. And this filtration rate and the filtration pressures are directly connected. So the rate increases either, that is of the urine formation. Now the second category is the intermediate acting mechanism. Now in the intermediate mechanism the first is the capillary fluid shift mechanism. Now this is a very some of the books mention here. This is very rare type of the mechanism, and it is not significant as compared to the other mechanism. What happens here in short, whenever there is increase in the blood pressure, there will be increase in the capillary pressure, and this increased capillary pressure will cause increased filtration of fluid from capillaries into the surrounding tissue, and this will result, or this will cause decrease in the blood volume, and therefore it will cause decrease in the blood pressure. Why? It has occurred due to the increased filtration of the fluid into the surrounding of the capillaries, which has caused decrease in the blood volume, and hence it will cause decrease in the blood pressure. When blood pressure decreases, there will be osmosis of the fluid from the tissues into the capillaries, that we know, and this will now help to increase the blood volume, and therefore blood pressure will increase. This mechanism is called as a capillary fluid shift mechanism. The second a mechanism which is included in the intermediate category is stress relaxation of the blood vessel. As we know that when there is an increase in the blood pressure, there occurs stretching of the vessel walls. When the blood pressure is increased, blood pressure will distend the blood vessel, and these larger blood vessels will help to cause increase in the blood flow and decrease in the peripheral resistance. Now this helps, or this will help to bring here the blood pressure back to the normal. Then coming to the long term regulatory mechanism, there is the first mechanism, renin-angiotensin system. This is very important mechanism. Renin is a hormone which is secreted by structome known as the juxtaglomerular apparatus in the kidney. I hope that all of you know what you mean by the juxtaglomerular apparatus in the kidneys. I will tell you. Now this renin is formed from the precursor called as the prorenin, that is the region what we call as macula densa, in the juxtaglomerular region, that the renin is secreted. Most of the part of the secreted renin, what is its action? Means as it is said that 75% of the secreted renin enter the circulation, and some of it remains. Some of the books mention 20% of it remains in the kidneys and extend a local direct effect on the kidney that causes an increase, that is the vasoconstriction. Local vasoconstriction. Now what is the action of this renin? The renin which is released in the circulation. Now this renin is an enzyme. It enters circulation and it acts on, that is the plasma protein alpha 2 globulin, that is what we call as the angiotensinogen, the alpha 2 globulin, and it converts it into the angiotensin 1 is a decapeptide containing 10 amino acids. Now further this angiotensin 1 reaches to the lungs, where the angiotensin 1 is that is the converted to the angiotensin 2. Why? Since that is the angiotensin 1 converting enzyme is present in the lungs, and hence it is converted as angiotensin 2. It is a octapeptide, but 2 amino acids are reduced from angiotensin 1. Now just if you remember that this is what we call as afferent and the efferent, that is the nephrons, and when they reach to the that is the blood capillaries, afferent and efferent capillaries. Now this region where it comes in the contact with the blood vessel, that we call it the juxtamedullary that is the apparatus, and there is inside that macula densa, the granular cells are there, and they secrete here renin, that all of you know. Hence I will not go in that much detail. Now the further just try to understand. Now when the renin is secreted by juxtaglomerular apparatus, it comes into circulation, it acts on alpha-2 globulin, means that angiotensinogen, it converts it into angiotensin 1. Angiotensin 1 is converted to the angiotensin 2 in the lungs, in the converting enzyme is say present in the angiotensin 2, present in the lungs. Now what is the action of angiotensin 2? Why it is important? All the time you must have heard ACE inhibitors means angiotensin converting enzyme inhibitor drugs are there. Now what is the action of angiotensin 2? So it is a very powerful vasoconstrictor. Means it causes severe vasoconstriction. It increases secretion of hormone aldosterone. It is stimulating. It is having the stimulatory effect on aldosterone from kidney, the adrenal cortex of adrenal medulla. And this aldosterone, what is the role of this aldosterone? It acts upon the kidneys and causes, say, that is the retention of sodium ions and accretion of potassium ions. Means it is, say, aldosterone acts upon the kidney and causes increased absorption of sodium ions. Locally, angiotensin 2 in the kidney causes powerful vasoconstriction like renin of afferent arterioles of the glomerulus, causing reduction in the filtration, because the say vasoconstriction of the afferent arteriole will say reduce the filtration. Angiotensin 2 acts as a strong thirst stimulator. It is having three effects. Remember that. It causes vasoconstriction. Secondly, it acts on the say that is the kidney to release that is the aldosterone. Third, it acts as a powerful say vasoconstrictor. Angiotensin 2 acts as a strong, most important effect is that it is a thirst stimulator. Means angiotensin 2 acts as a strong thirst stimulator. It causes consumption of large volume of water, causing rise in the blood pressure. Since here say that is say what it causes powerful vasoconstriction, and it say reduces the reduction in the filtration, and it causes the say thirst stimulation, which helps here for consumption of large volume of the water, and that helps here say causing the rise in the blood pressure. The mechanism also play some role in long-term control of that is the blood pressure. Now angiotensin, now there is the same say enzyme angiotensinase. Now convert say angiotensin 2 into angiotensin 3. Now angiotensin 3, what is its action? Has say up to certain extent, about 40%, say it is having the 40% of the pressure activity, vasoconstrictor activity like angiotensin 2. But 100% of the aldosterone producing activity, means it is a strong stimulator for aldosterone and increases, and that helps here to increase that is the main arterial pressure. Now finally it is say converted in the angiotensin 4. Now angiotensin 4, I would say it is the end product, is a hexapeptide which like angiotensin 3 has some lesser activity, lesser say that is the vasoconstrictor activity. This renin-angiotensin mechanism takes about 20 minutes for its activation, but once it starts functioning, it brings back blood pressure to the original level. The stimulus for secretion of the renin, you have learned that is a decrease in the sodium ion, and that you know that it causes the stimulation of secretory granules in the say juxtamedullary, say that is the apparatus, that is macula densa. This will occur when there is a fall in the blood pressure, a decrease in the extracellular fluid volume, or any other condition decreasing sodium concentration. When the secretion of renin will occur, when there is a fall in the blood pressure, or there is a decrease in the extracellular fluid, or there is any condition which will cause decrease in the sodium concentration. The fall in the blood pressure will decrease sodium load because there will be decrease in the quantity of the blood reaching the juxtaglomerular apparatus. Direct action of renin on the kidneys is caused by the small quantity of renin which remains within the renal tissue that we have seen. The direct action is that it causes vasoconstriction of the renal blood flow in the kidneys, which allows a larger amount of the sodium ions to be reabsorbed from the kidneys. Out of these two mechanisms, say that is the direct effect is more powerful. Two mechanisms, what that is the vasoconstriction and absorption of sodium ions. That out of these two mechanisms, the direct effect is more powerful as compared to the effect produced by increasing aldosterone secretion. Renin-angiotensin system is an automatic feedback mechanism which helps to maintain arterial blood pressure to normal level. What is the stimulus for the renin? Say just to occur in a negative feedback manner. Remember that there must occur decrease in the sodium concentration, then and only in the feedback manner there will occur, say, that is the release of renin. Then, now this is a short summary of this, what happens here in the renin-angiotensin system. When there occurs decrease in the blood pressure, there occurs a secretion of the renin from the kidney, which acts on the alpha-2 globulin, that is the angiotensinogen, that is in the plasma. It is a plasma protein and it is converted to the angiotensin 1, and we know that it reaches to the lungs, and there is a angiotensin converting enzyme which converts into angiotensin 2. Now it is a very strong, say, vasoconstrictor. It stimulates, say, that is the adrenal cortex of the, and release cause here adrenal cortex, adrenal gland, stimulation of aldosterone, and this aldosterone helps here to cause increased water and the sodium retention, and this will help here to cause here, say, increase in the blood pressure. Similarly, now this angiotensin 2 is having strong vasoconstrictor effect, that also helps here to cause increase in the blood pressure. Now we have also seen the role of angiotensin 2 and angiotensin 3. Here, say, angiotensin is once again converts, say, this angiotensin 2 into the angiotensin 3, and once again, say, it helps to, say, bring back, that is the, say, that mean that this girl to, say, that is the her home, because in the sense that she has suffering from, say, that is the increase, or say that increase in the blood pressure. And next is, that is the other mechanism in the renal body fluid system. This is a very primitive type of the mechanism. This is a primitive system which is also developed mainly in the lower animals. Now what is this? It is a simple mechanism. It is a simple system in which output for excretion of the H2O and salt by the kidneys is very sensitive to the pressure changes. Means, for example, say, if there is increase in the blood volume, will cause increase in the blood pressure. Due to this increase in the blood pressure, the kidneys, say, cause filtration, that is, causes kidneys excrete excessive amount of H2O and the salt, and then when there occurs the excessive release of water and the salt, we call this as a diuresis, and the salt in the urine we call the natriuresis, because it is due to an increase in the blood pressure, which has occurred due to increase in the blood pressure, which is also called as pressure diuresis, it is called as pressure diuresis or pressure natriuresis. It is by mistake, it is typed here twice. When blood pressure is within 15 mm of mercury, there is no output of H2O and salt by the kidney. But however, remember that when the pressure is about 100 mm of mercury, the output is that is the normal. But however, if, say, this pressure reaches up to the 200 mm of mercury, then output of, say, water and the sodium, so increases 6 to 8 times the normal level. And when there is a rise in the extracellular fluid, blood pressure rises, kidneys will excrete extra amount of fluid and the sodium till, how long it will occur? Till the blood pressure comes back to normal. If there is a decrease in the extracellular fluid, now on the contrary, blood pressure will decrease. There will occur excretion of water and salt, and, say, will decrease, and both will be retained till blood pressure becomes normal. That will help here to maintain, that is, normal blood pressure and water, and that is the sodium ions. Exactly opposite effects are seen when salt intake is decreased. When salt intake is also decreased, now means instead of, say, increasing blood pressure, that will here, say, that is say, it will cause here, say, that is the means that is the decrease in the that is the blood pressure, and that will lead to this mechanism will here help to normalize or to increase, that is the blood pressure. Means what is this mechanism? When there occurs a salt increase in the salt intake, there will occur increase in the extracellular fluid volume, and that will here cause increase in the arterial blood pressure, and that will increase the renal blood flow. Now the retention and that also help here, the retention of the salt and water, and that will help here to maintain normal return of extracellular fluid volume to the normal, and that will cause return of, that is, blood pressure to the normal. Now that is once again I will not go in that much detail. Now this renal body fluid system, if you want, now in short there are two factors determine the functioning of this system: excretion of salt and water by the kidneys. We have seen the intake of the salt and the water by individual. Whenever there is decrease in intake of water or increase in the salt intake, the body causes increase in the extracellular fluid volume to maintain normal osmolarity, and this increase in extracellular fluid at the thirst center, which will cause increased intake of water, hence osmolarity becomes normal. Increased osmolarity stimulates secretion of ADH, which acts on the kidneys to cause reabsorption of water, and this increased water also helps to bring osmolarity to normal. In short, it maintains normal extracellular fluid volume to maintain normal blood pressure. Now what we have seen so far? We have seen here so far that is about that is the blood pressure, that is about the blood pressure and the various regulatory mechanisms. The next important topic is that pulse, or pulse means what? Or arterial pulse. We never say that it is venous pulse. We never determine, where we are not able to determine that is the pulse of the vein, but we are able to determine the pulse in the artery, because arteries are built for higher blood pressure. Now how do we define this arterial pulse? The rhythmical expansion of the arterial wall caused by the systolic rise in pressure is called as the arterial pulse. Means when the blood is that is the flowing with the high pressure and the high velocity, what happens? It causes the rhythmical expansion of the arterial wall by the systolic rise in the pressure is called as the arterial pulse. Or the other definition is that the alternate expansion and elastic recoil of an artery with each systole of the left ventricle is called as the pulse, and hence that is rhythmical expansion of alternate expansion, alternate relaxation, or inelastic recoil of an artery by systolic rise in the pressure is called as the arterial pulse. Why it occurs? Due to the left ventricle. It doesn't occur due to the that is the right ventricle, since it is a low pressure system. Pulse is strongest in the arteries which are closest to the heart, and becomes weaker as it passes over the arterial system, means as the blood passes further to the arteries and the arteries. The pulse may be felt in any superficial artery near the body surface, over the bone or other firm tissue, that is the, for example, that is the radial artery. For example, radial artery. Okay, we just try to understand here. The pulse may be felt in a superficial artery near the body surface, over a bone or other firm tissue, for example, radial artery. Now these are these are the various types of the arteries which are present over the superficial artery, which are called superficial artery. The superficial temporal artery, which is present at temporal bone, facial artery at the bone of the medial, common carotid artery, brachial artery in the upper arm, radial artery, then that is femoral artery at the groin, then popliteal artery at the backside of the knee, then posterior tibial artery and dorsalis pedis artery. These are the that is the approximately 9 arteries are there, superficial arteries, which are shown in the figure. Now just to mention here about their position. Now the temporal artery, which is lies above and towards the outside of the eye, or we say over the temporal bone. Facial artery at the lower jaw bone on a line with the corners of the mouth or mandible joint. Common carotid artery on the side of the knee. Brachial along the inner side of the biceps or brachii muscle. Femoral artery near the pelvic bone. Popliteal artery behind the knee. Posterior tibial artery behind the medial malleolus of the tibia. Dorsalis pedis artery over the instep of the foot. Then there are also other artery, occipital artery, ulnar artery, radial artery and subclavian artery which can be easily palpated. Now how do we say that is the examine, that is the palpate? They can be easily felt. Now as shown here in the figure, this physician here say palpate these arteries with his two fingers, that is say that is here say index finger and that is the middle finger. Maybe everybody is having the different style, but generally we just determine or feel the pulse with say that is 3 digits of the finger, that I will show you here. Say as now just see this figure or just look at me. Just look at me. Now say these are the 3 fingers or 3 digits. Now this is the index finger, this is the middle finger and this is the say that is the distal finger. Now what we do? Now all of you know that where this radial artery is present, this is present at the say below say that is the this portion of say thumb or what we call it is the ulnar border, and here say this say right. Now what you have to do, just fill the your say with put over these 3 fingers over say this radial artery and just realize say that is pulse at or the beat of the artery, mean that is expansion and the relaxation at the tip of the middle finger, mean you are able to palpate say that is radial artery and you feel what you are feeling is that is what we call it as a pulse. What we call it as a pulse. Then as shown in the figure there are say different ways how do people say that is the palpate artery. Now you are going to study a different separate practical on say that is the pulse or arterial pulse, how to determine. Now the pulse is having say, now there are say other say that is a say as shown in the diagram, that is the elaborate, just to elaborate the arteries. Now where they are present, just say go back to say this figure. Where we were? Now there are say slide this is the he could he diagram this. Yes. Now you can see in this diagram, say now how this physician say palpate in different way the say arterial pulse. Now these are the different methods, but we will just rely the palpation of the radial artery by these 3 digits which I have shown. Just to elaborate the other diagram, you will find where this femoral artery is present, then say what is its location, the popliteal artery behind the knee, dorsalis pedis where it is present, and the posterior tibial say that is the pulse. Okay. Now what are the properties of the pulse that we are going to study? What are these properties of the pulse? How to determine the rate? That is, say these are the some of the properties of the pulse. Now rate, we determine rate, rhythm, strength, amplitude, tension of the pulse and condition of the vessel wall, and that is the say that is the equality in the other, say in other artery. Okay. What is this? What is this? Say rate means what? It correlates with the heart rate. That is means normally we say at an average we have the habit to say how much is the pulse rate. We say 72 beats per minute. But here rate is say that should be in the range of 70 to 90 beats per minute. Now rhythm. when you are feeling, say, that is the, say, pulse, that now just say concentrate, that I will show you just now, say concentrate between, that is the successive occurrence or feeling of the, say, that is the pulse. Now what you will find, that whether you feel it regularly, mean that is we call it the regulatory of the pulse beat, mean we call it the regular pulse, regularly irregular pulse, irregularly regular pulse, and so on. Now the strength, the force needed to compress the artery till pulse disappears. Now amplitude, now this is the fourth character, mean that determines or gives us idea about the volume, and that is really related with the expansion of the arterial wall when a new volume of the blood, say, enters the arterial system during ventricular systole, or impact can be felt, mean upthrust which is given to the, say, the tip of the, say, your middle finger, that indicates, say, that is the stroke volume and pulse pressure. So the fourth characteristic is the tension of the pulse. It is the feel of the artery between two pulse beats. It is a measure of diastolic pressure. In low tension pulse, hypotension, the vessel is soft or impalpable between two beats, while in high tension pulse, that is in the hypertension, it stands out, say, like rigidly, like a cord of or tendon. That is we call it tension of the pulse. Condition of the vessel walls. Now normally in your age group, if you just try to palpate, we will say radial artery, you will not feel. In the young individual, say this radial artery are not palpable, but the individual like me, you will find that, say, you can feel the thickness, hardness of my, say, that is walls of the blood vessel. Now equality in the other artery, means you have to compare that is equality of this blood vessel at the other side. Mean if you are determining, say, that is on the, say, left side, now you have to determine the same characteristics on the right. Mean these are the some of the properties of the pulse, that is what we have to determine: rate, rhythm, strength, amplitude, tension of the pulse, condition of the vessel wall, equality in other, say, artery, other artery. Now there is one important property, that what we call as pulse deficit. Now what is this pulse deficit? Now this pulse deficit relates to the difference between the heart rate counted by the stethoscope and pulse counted at the wrist. Means generally we correlate our pulse rate with the heart rate, but many of the times what happens, if you just determine, say, your heart rate with the stethoscope, a fifth intercostal test, what you will find is that here, say, the heart rate will be different, or pulse rate will be different. Now this difference between the heart rate and that is determined by the stethoscope and pulse counted at the wrist, we call it as a pulse deficit. It occurs when some of the ventricle contractions are too weak to open the aortic valve and hence produce a beat at the heart, but not at the wrist. Means these weaker contraction of the ventricles causes, they are very weak to push the blood volume toward the periphery of the radial artery. Hence you find the difference between the pulse and that is the heart rate. Now we can obtain, say, that is the, say, that is graphical record of the pulse, and that is called as the sphygmography. The instrument which is used is called as the, say, sphygmograph, Dujon's sphygmograph, and the record is called as the sphygmogram. Okay, what is that we will see, and in the next lecture I will tell you how to determine, that is the property of the pulse. Okay, now I will stop here. Thank you very much for watching.